Next speaker is Dr. Smitha VK. Dr. Smitha is Senior Glaucoma Consultant at Little Flower Hospital, Angamali. And Dr. Smitha is going to speak to us about classification and clinical features of primary angle closure disease. Over to you.
Good morning all. My topic is classification and clinical features of primary angle closure disease. Primary angle closure disease constitutes about 3 to 5% of Indian population over 40 years. It occurs when an anatomically predisposed eye undergoes physiological changes in the configuration of iris, which leads to apposition of the iris to the trabecular meshwork. This iridotrabecular contact prevents the aqueous outflow and results in increase in IOP. This increase in IOP depends on the extent of circumference of the angle closed and the speed with which it is closed. The relative pupillary block is the main pathomechanism for the angle closure. And here, when the pupil is mid-dilated, the iris is in contact. There is more iris contact with the lens, which leads to increase in pressure in the posterior chamber. This increase in pressure in the posterior chamber prevents the aqueous, leads to the iris bowing peripherally, which leads to the iridotrabecular contact and prevents the aqueous outflow. The risk factors include age. With increased age, there is increase in the lens thickness and there is forward movement of the lens, which results in angle closure. And females are more prone for angle closure disease, and hypermetropes are more likely to have angle closure. And Southeast Asian population is at more risk. And if there is a family history of angle closure, there is high risk for angle closure. And the ocular biometric factors include shallow anterior chamber, thicker lens, anteriorly positioned lens, shorter axial length, small cornea, anterior insertion of the iris, and steeper cornea. If the pupil is mid-dilated, especially in twilight or in theaters, there is increased risk for angle closure. And with increased stress, there is pupillary mydriasis, which leads to angle closure. With the new techniques like UBM and anterior segment OCT, newer factors, anatomical factors have been identified. It includes the decrease in the anterior chamber width, area, and volume. There is increased risk for angle closure. And if there is increased iris thickness, increased iris area, and increased iris curvature, it can lead to angle closure. And increase in the lens vault is another factor which leads to angle closure. And choroidal expansion can lead to forward movement of the iris lens diaphragm, which can cause angle closure. This is the pictorial representation of this. And clinically, the angle closure glaucoma can be classified into a preclinical stage when one eye is in acute attack, the other eye is said to be in the preclinical stage, and it can go into an attack stage where it may be a mild attack or an acute attack. In mild attack, there is incomplete closure of the angle with mild rise in IOP and symptoms, while in acute attack, there is sudden increase in IOP with complete closure of the angles, and this can reverse to go to an intermittent stage when the angles can get opened and IOP getting controlled. If the angle keeps on closing, then it can go to a chronic stage where where there is increased IOP and glaucomatous damage. And in absolute stage, there is a refractory eye pain with glaucomatous optic atrophy. And ISDO has classified primary angle closure disease into primary angle closure suspect, primary angle closure, and primary angle closure glaucoma. This helps in planning the management of angle closure, but this ISDO has not taken into account the optic nerve damage or trabecular dysfunction. So, in primary angle closure suspect on gonioscopy, we can see an occludable angle. Here, the posterior trabecular meshwork is not visible in 180 degrees of the circumference of the eye in primary gaze without indentation, and you have to use a slit beam of 1 millimeter height. And shallow anterior chamber is seen in primary angle closure suspect, and where Van Herrick's estimation, we can compare the peripheral anterior chamber depth with the peripheral anterior corneal thickness, and if it is less than 1/4, then they are more prone for angle closure. And in primary angle closure, there is an occludable angle with signs of iridotrabecular contact and with or without raised IOP. The signs of iridotrabecular contact include peripheral angiosynechy, iris swelling, blotchy pigment deposition on the trabecular surface, and glaucoma flecken. And you have to see the optic nerve head carefully, as the disc will be small and we can miss the glaucomatous changes. In primary angle closure with hypertension, the eyes will have increased IOP, and this may be due to the peripheral angiosynechy, or if the angles are open, it may be due to the deranged trabecular meshwork architecture and function. In acute angle closure glaucoma, the patient has diminished vision, eye pain and headache, sudden onset of headache, nausea, vomiting, rainbow colored halos, etc. And the signs include increased IOP, circumcorneal congestion, corneal edema, shallow AC, vertically mid-dilated, poorly reacting pupil, and a closed angles on gonioscopy with a swollen hyperemic optic disc. And the signs of previous episodes of angle closure include Vox triad, which includes segmental iris atrophy, pigment dispersion, and glaucoma flecken, with a fixed mid-dilated pupil, shallow anterior chamber, and peripheral angiosynechy on gonioscopy, with posterior synechy to lens and optic nerve head pallor or cupping, and visual field constriction. In primary angle closure glaucoma, there is an occludable angle on gonioscopy with more than 180 degree of peripheral angiosynechy and raised IOP, and there is glaucomatous optic neuropathy with visual field changes. Chronic angle closure glaucoma, the portion of the angle closed permanently with peripheral angiosynechy and IOP is raised. The angle slowly closes from the periphery towards the Shalby's lines. So usually starts in the superior quadrant and it progresses inferiorly. This is called, otherwise called creeping angle closure. And in plateau iris syndrome, it usually occurs in young people when despite the laser PI, after laser PI also, if the IOP patient gets acute attacks, then you have to suspect this plateau iris syndrome. Here the anterior early position ciliary processes push the peripheral iris anteriorly and it gets punched up and leads to the closure of the angle. And gonioscopy shows double hump or sine wave, and UBM is confirmatory. Thank you.